Thank you very much. I really appreciate the opportunity to come here and speak today. I'm not a practitioner of really the field that we're talking about here, this geospatial science. But I think what I'm going to talk about today may be tools that can be integrated with the types of things that you guys are all working on. So I think if we look at it from that point of view, I think that will be maybe the value add that I can provide. As I say, I come from my background is in nanotechnology, so I spent a good chunk of my career building very, very precise machines that could do very, very precise things. A couple of good things came out of that. One is that I got tenure. Another thing, we started some companies and so forth. Now, what I'm going to talk about is almost the opposite end of that, which is, how do we not necessarily concentrate on building the, most precise machines, but how do we design something to enable it to be used at a very broad level and focus on, say, consumer uptake or something like that. So that's mostly what I'm going to talk about today. I'll start off by doing the thing that we all have to do here, which is we're at least mostly employees of Cornell. As you know, then you get a discount if you join the Cornell Plan for Healthy Living. And what that requires you to do is get a blood test every year. And you get, I don't know, you save a few $100. So in June is when they start sending you the letters that you're going to lose your few $100 if you don't go to the doctor. And so I started to get my act together, planned that. Of course, in June you don't know your teaching schedule, so made an appointment for October 1st. October 11th, I had to cancel that. October 11th, finally got it. Took me 2 hours. October 23rd, visited the doctor and told I was vitamin D deficient. And told to take supplements and said come back in a year, which was by that time about 2 months. And so you can sort of see the obvious problem here, which is that my diagnosis was simple, but it took a long, complicated time for me to obtain that information, right? What's the reason for that? Well, if you look at the kinds of, say, personalized diagnostics we have, they broadly fit into two types of categories, right? So one is these, say, a glucose meter for a diabetic, right? So that's an acute condition that requires some level of quantitation. Okay, I need to know a number. And I need to do it quite frequently, right? I need to know that number quite frequently. And so in that case, if I'm a manufacturer or, on the device side, I might be willing to, either give you a reader or add some fancy features on it and take a hit on it commercially, because I know I'm going to be selling you tests for the next 2 years. The other thing that's successful are these sort of binary tests, right? Where I don't need to necessarily test whether I'm pregnant 3 times a day. So it's an infrequent measurement, but I do need to know, and it's a binary result, right? I'm either pregnant or not pregnant. And so it's the two sort of things that are, workable are these quantitative results, but you need a lot of measurements to get that workable. And these binary results where I, don't need it that frequently, but typically I can engineer a system that can be cheap enough to make it worthwhile for me to just buy at the store, so long as that measurement is typically binary. If we look back at my blood test here, almost nothing actually fits into that category, right? So we look at cholesterol. I'll go into this a little bit more later, but 60% of Americans have high cholesterol. I think high cholesterol is responsible for something like 5% of all deaths worldwide. Don't need to measure it 3 times a day. Micronutrients and vitamins, I'll talk about that. That's going to be a focus of really the Nutrifone project that I'll go into. All these things, again, in particular vitamin D here in the United States, good to know, can be a chronic type condition, but not the type of thing that I'm probably going to buy a vitamin D machine for in my house, right? Pregnancy and conception, again, we talked about pregnancy testing, but things like tracking ovulation cycles and so forth. Again, really nice to be able to have that information, difficult to do in a non-quantitative manner. And there's many, many others. So, there's this paradigm of a lot of information I'd like to be able to have, but no real, successful business model to be able to do this, right? All this stuff, anything here, I could come up with a machine that could do it for you. The design would take literally hours, right? There's no technological thing. So why don't we have them? There's, of course, a number of other industries that have faced this kind of exact thing, where you have a lot of people that kind of do things at a low level that if you could enable them to do it, you would be able to capitalize on that. One of them is the smash truck. So for those of you, this is a food truck in Ithaca, New York. They're set up here. This is at 6 Mile Creek Winery this weekend. Brandon Fortenberry runs the food truck. He's also director of Cornell Catering, so that's the guy who maybe is putting your food together today. They make a lot of, I'm sure they'd like to make more, but they make a lot of small purchases, right? People make a lot of small purchases there. And you're set up outside a winery, you want to be able to, people on a wine tour, they may not be all coherent, you want to be able to get their money from them as quickly as possible. So you'd like to be able to make credit card payments, right? But because there's sort of, we've got this truck, we've got all these other things, I don't want to have to worry about, another thing. It's difficult to maintain that infrastructure if you're only using it for a few times, a day, maybe once a week. You maybe don't want to either buy that infrastructure or even own it and maintain it, right? So it raises the bar to being able to obtain that information. So a good startup from about a year ago, or from several years ago, but made the leap in being able to allow smartphone-based credit card payments. Okay, it's called Square. This image is extremely clear in what it enables, right? It allows me to both capture that information, or I buy that little thing at the top there, put it on, and sorry, my thing isn't particularly bright. Run my credit card through it, and I can essentially attain that money gets transferred to my account. I'm sure I get paid every time, right? I don't have to worry about that. They collect 3% off the top, and I can buy it at Starbucks for $10, right? So that's sort of transformative for that kind of thing. So what we want to do really is do this, but for these types of diagnostics. And so this is an early version of our device. We'll go into the components later, and I have a prototype up here, if you're interested in taking a look at it during the coffee break. But the upshot of it is it's a little device that's similar to this Square system that fits over the corner of the camera. We have a test strip that goes in and out. That test strip varies depending on what you want to measure. In this particular case, it interfaces with the camera. After a certain amount of time, the smartphone runs the test, images the test strip, and then relates that back to a cholesterol number. You can see there's sort of a lot of similarities between this, and that is just a very small thing that fits over the top. We're, of course, engineers, and so the first thing an engineer wants to do is add features. And so I see Dakota, one of my graduate students, is up there. He can attest to all the crazy things that we had originally on these devices opening up, flipping open. Here's where I obtain my test strips, whatever. Turns out people don't want their device opening up to reveal that they're tracking their ovulation cycle. So, what ends up being useful is something that can come on and off quickly. So why smartphones? Just to make the case. Again, I think from the GIS perspective here, I think it's maybe pretty obvious in the sense that it has a lot of features that, for example, if you want to take population level data that we'd be able to extract, you can both geolocate that and locate that in space and time. If you were a user, you're interested maybe in linking up with Facebook. There's a lot of computational power, et cetera. From a user point of view, it's also extremely rugged. You've probably never, I'm sure you have never had a machine as complex as you know, the combination of complex and rugged in your pocket as the iPhone. Important for diagnostics, again, is that you're already trained on it. So a big problem with a lot of devices is having to train someone on them. You know, my 2-year-old can flip through the iPhone to find pictures of him and his brother. And best of all, you already own it, right? I don't even need to sell it to you, right? And then, of course, smartphone adoption. So this is, let me just go into a little bit of technical detail here about what some of our systems look like. This was the early version for cholesterol, smartphone cholesterol app for rapid diagnostics. Again, the system, I mentioned it earlier. These, it's a test strip that fits into an accessory that just sort of clips on and off of the smartphone here. These test strips are already FDA approved. And so you can see the device just kind of comes on and off. Simple as that. Test strip goes in and out like so. The app on the phone both interprets the results and helps you run the test. So it does timing, looks at these sorts of things, and does a few other things that are helpful. I won't talk about the details of the test, but it's basically a colorimetric enzymatic reaction. Risks of high cholesterol, again, so this is, I tried to put it, here's a map. So this is probably, here's something you guys are more up your alley maybe. You know, mean blood cholesterol, you can see here, you know, so the sort of redder is where locations of higher cholesterol. So you can see here in sort of North America, Europe, Australia, we tend to have very high cholesterol. Other places tend to have lower, but you can see there's growing numbers all over the world. The WHO cites 5% of all deaths annually as resulting from high cholesterol. And something like 70% of Americans have, American adults, so that's not 7% of Americans, American adults have not had their cholesterol tested in 5 years. And that's, you know, 60% of people have raised cholesterol levels. So, you know, one of the things, we have treatments, you know, we can provide information on people being able to reduce cholesterol levels, right? You know, we can assign statins or lifestyle changes, but it's very difficult to do that if you don't know, if you're not getting any feedback or anything. So our first idea here, this was monitoring cholesterol levels. This is a little bit, just some technical details here, again, just fitting in the back. These devices tend to be very simple and are mostly, there's a couple of versions, but they're mostly engaged in trying to ensure you get proper uniformity of lighting and these sorts of things. So in order to obtain a good image, you have to have uniform conditions inside, outside, day, you know, day, night, raining, not raining, etc. A lot of the work we've done is in trying to get that to work. This is just some results in user trials. So this is what we predict with the smartphone system versus actual cholesterol. We get accuracy of about 5%, something like that. Here, in terms of detecting, again, this is something I didn't hit on earlier, but I think is useful, is again, because you've got access to a lot more computational power, you can do a lot more calculations on the phone itself, and that allows you to do things like spot erroneous measurements much more accurately. So this is just an example here of looking at the hue axis. You can see we get good, we expect our measurements to be up here. When we get measurements that are not out there, that are clearly out of the range, it's a very easy way for us to diagnose either a bad strip or a bad user. So then let me just touch on the Cornell, this Nutrafone project that we're getting off the ground that sort of builds on those ideas. This is something that Professor Saurabh Mehta and I have been working on the order of 2 to 3 years, trying to get off the ground. Initial funds came from the Atkinson Center, which many of you are familiar with. We recently received $4 million, or almost $4 million from the NSF to support these types of technologies over the next few years. Again, it really is the extension of that device that I showed earlier, trying to build off this platform to be able to do a broader range of tests. The way we're expanding it right now is towards micronutrients. There's a few other things that we've done in the past that I won't talk about, but it's sort of we're moving on this axis this way. There's a couple of reasons why vitamins and micronutrients are sort of an interesting thing to look at. One is there's impact broadly, both domestically and in what we call limited resource settings. So this is vitamin A and zinc deficiencies are I don't have great statistics here, but I could certainly provide them. So worldwide, vitamin A and zinc deficiencies are a major cause of mortality and morbidity. Micronutrient deficiencies affect 75% of U.S. adults. This is vitamin D. There's, you can find articles all over the place. As mentioned, they tend to be chronic problems, which means, knowing your level on one particular day is of very little value. Tracking over a lifetime is of much more value in enabling that. Another thing is on occasion can certainly get measurable and quantifiable feedback. So one of the things we need to be able to do with these, as part of those efforts that I briefly mentioned, there's a team of sort of sociologists and product development people on the industry side that not only do we need to develop the technology, but we're able to show efficacy. And in some cases, certainly for micronutrients, it should be a little bit easier to show efficacy in the sense that we can assign a pretty easy therapeutic, for example, if you're vitamin D deficient. And being able to show that given access to this type of information, we can make an impact on an easy measurement like that is the type of thing we want to be able to do. And then again, say a lot of this, as a lot of the work that we do in my lab, we try to be able to transition it. And another reason why this particular thing has attracted some industry interest is, of course, there's a huge vitamin and supplement market out there. And if we can tie the results of this to that, directly to the vitamin or supplement market, then it becomes there's a higher bar for regulatory concerns, but it becomes attractive from from industrial point of view. This is again, so as I say, our first work on this Nutrifone is going to be in vitamin D status, mostly because that was what we could attract interest from in a domestic point of view. I won't go into the details, but the assay is a slightly different assay here. In the sense that basically there's a nanoparticle type binding assay that occurs, and basically by imaging the difference between between a reference area and a test strip area, taking the ratio and then taking some ratios internally here, we're able to extract out some quantitative information with regards to the assay. And then the smartphone algorithm, again, just basically takes a scan, takes an average of the different areas, and then back calculates based on an earlier calibration what the actual status should be. Again, more just results in terms of vitamin D deficiency testing. This is in serum, so this is not at the level of the cholesterol testing. This is just early results on some serum samples, showing we get, at present, not as good, maybe like 10% type, not so good at the lower levels, but at higher levels, sort of 10% accuracy, and hopefully we'll improve on that. And then, yeah, just to make a plug for where we're moving now. We sort of shifted gears to vitamin B12 testing and developing a test for that. Again, there's a lot of Americans, but there's also, again, some significant pathologies that can result from chronic vitamin B12 deficiency. And our plan is, again, just in terms of something that may be of interest to this crowd, our plan is to start larger scale testing of these devices in India with Saurabh here again. This is at his testing site 2 hours outside Bangalore. Our hope is to start kind of doing, village scale type testing. Initial testing at the beginning of, around July of this year, and then larger scale testing maybe the year after that. So that's the type of information that could start feeding back into the types of maybe data or types of analysis that you that people here might be interested in. So I still got a few minutes. Okay, so let me go through. Of course, one of the really nice things about the uses of smartphone type technology to deploy these types of tests is that it is not just a the uptake is not just domestic, and certainly the prevalence of cell phones and more and more smartphones, the penetration of that into places that typically have lower resources is higher and higher, right? Even 10 years ago, whoops, I couldn't do that again if I tried. 10 years ago, even as I say, more than 10 years. I guess I'm older than I was when I started telling the story, but roughly 10 years ago, we were backpacking my wife and I backpacking through Kenya, and the guy we were with, just gets a call from mom back in Norway, right? And that was over 10 years ago. So the advancement of the mobile networks in some pretty remote places, can be quite robust. The anecdote is sort of shown here. This is This is in a rural clinic outside, or not rural, I guess a clinic outside of, or in Kitale, which is maybe 60 kilometers outside of Eldoret in Western Kenya. Earlier this year, we were field testing some of our this device that I'm going to talk about here now. And while we're there, my collaborator took some pictures to try to, the next NIH proposal, at least where, you can, here's the PI, and here's in the clinic, and here's the student doing all kinds of things. But of course, we'd buried the lead on this picture and didn't realize it until we got back, which is that, we put out the device, everybody comes over to kind of demo it, and the first thing everybody does is take out their cell phones to take a picture of it. Right. So again, it's just the availability. This guy, so I can't really. This guy here is the physician at the clinic. You can see he's not taking a picture, but you can just make out here. That's his iPad that he carries with him everywhere. So it's not just a domestic thing. This is the particular disease that we were engaged in. There is something called Kaposi sarcoma. It's an AIDS-related cancer of lymphatic endothelial origin. Again, given that I have time, I'll just go through it in a little bit of detail, but it's caused by co-infection with the Kaposi sarcoma herpes virus, HHV8, in immune-compromised people, which in sub-Saharan Africa tends to be AIDS people. I'll talk about maybe some data later, but it also still has high rates of mortality even after the introduction of antiretroviral treatments. This is this is just a breakdown in sub-Saharan Africa of, again, probably this data. I showed this type of data at the last time I spoke in earlier this year in Kampala, and they have some things to say about this data, but it's certainly the best data that I have. And you can see here Kaposi sarcoma, kind of, not the most common, but kind of at this rate. You can see here the difference between incidence and mortality is not particularly high, and so the mortality rate is still quite high. There's a couple of reasons for this. For the reason why the mortality is quite high. Late diagnosis is one, lack of medical infrastructure is another, and lack of access to chemotherapy is another. Of those, it's pretty difficult for me as a professor here at Cornell to address the lack of access to chemotherapy or medical infrastructure, but what I might be able to do is develop some technologies that can sort of push up the diagnostic time frame and make that quicker. If you look at when diagnosis is typically made, some recent studies, this is 2009, something between 69 and 86% of diagnoses are made at T1 stage. You can see this is from an image from Jeff Martin at University of California, San Francisco here. Their efforts to try to get people to get into clinics to reduce that, push things to an earlier stage. There is evidence that there is evidence from a few studies to show that if you can get people diagnosed at T0 stage, you can increase mortality, even reverse the cancer through antiretroviral treatment. Like as I say, the physicians that I talked to at the major hospitals, at least in Kenya, say they never see anybody at that stage. By the time they get to them, it's way later than that. Maybe I won't go through this in too much detail, but this is just sort of the reasons why barriers tend to be late. The average time is about 7 months between somebody noticing lesions and some of this data is going to be out of date, but the upshot of it is that it's on the order of a big chunk of time between somebody starts noticing problems and when they start obtaining lesions or getting providers or getting information. There's a lot of sort of structural issues in terms of logistical cost of transport, household activities, basically not too different from the kinds of things that stop us from getting diagnosed. So what we've been trying to do is, one of the things that we try to do is develop sort of a point of care type site or a point of need type test that can go out, perform a diagnosis on site and try to get some results in the order of sort of 30 minutes or an hour, something like that. This is the system here. I have, if anybody's interested, I brought a prototype with me. It's actually the wrong prototype. I must have grabbed the wrong one this morning because it's only about half here. But you can see the full system here. It basically is a contained kit like this that has it's solar powered, so uses a little bit of solar panel to run a pump, and then a lens type system to heat up a chip to do a PCR. Looks for a genetic signature of the cancer, or of the virus, I should say. This is the system set up. Again, the idea here is that you want to be able to rely on as little infrastructure as possible. So we're taking advantage of sunlight here. Again, I don't think I have my data here, but Kampala, for example, is right on the equator, so you tend to get much more uniform sunshine over a much broader portion of the year. This is the way it works. Essentially, there's a microfluidic cassette that goes in, tilt the stage towards the sun. We have an app on the phone that measures the temperatures on the chip. Don't have time to go into the biochemical details, but for those of you that know, this is basically a PCR type reaction. Basically, it uses a thermal cycling reaction to heat up the sample, cool it down a number of times. That amplifies the amount of DNA. We can then, by looking at the DNA, determine whether it's positive or negative and quantify it. This is sort of how it works. Again, the lens comes in. It creates a thermal pattern on the chip. We can precisely control that thermal pattern basically by using a shadow mask. So in the same way that I'm putting my hand here, I'm casting a shadow on the system here. That's going to affect the heat of this. That's the heat pattern of that the projector is making on this screen. We do the same thing for this and create a nice thermal pattern that we can obtain. Get these nice thermal patterns and basically cycle the sample in and out of it to do this reaction. Let me skip over this. This is just a bunch of data showing that it basically works. This is some limit of detection type stuff. So just showing that basically starting with initial copy number, we can get some level of quantitation. Most important for us right now is being able to obtain a limited detection that's consistent with the biopsies that we're taking. And so if you do that, we're kind of in this range. We need to be at kind of 10 to the 6. And you can see we get kind of results in kind of that 30-minute time frame and so forth. So, we're sort of working. One of the problems that you run into, of course, this is from on the street in Eldoret. If you're ever there, you will have a very, very, very difficult time choosing a shop to buy a phone at because there's a zillion of them. This one here, Rift Valley Phones, I guess I can recommend. That's where gave me the best deal. One of the problems, the reason why I showed this this point is you can see there's a zillion different models from a zillion different makers, from a zillion different people who are knocking off those initial makers. And so being able to make your tests compatible with those ones, I brought one with me here. It actually has a spelling error on the front cover here, if you're interested. There's a challenge in being able to ensure compatibility between, if you're making a test that's going to run off a smartphone, off anybody's smartphone, this is obviously a problem. So we do have, the only thing that comes close to a standard is of course the Android operating system. People don't know this, but there's something like 10x the number of Android phones around than there is iPhone, than anything else. And partly that's mostly because of flexible licensing, of course. So this particular version, this is actually showing. These are screenshots. We have it running off this this particular phone here also, which again I bought for 4,000 shillings. And it runs via Bluetooth off the machine. Yeah, so the app basically comprises of a couple of different things: temperature sensor, micropump, fluorescence detector. You can imagine once we get these types of technologies deployed, being able to do these tests on site now feeds into some of those map type data, and you can collect better data over long periods of time. This is just some human samples, again, just showing. We use a fluorescence-based detection technique, and then in this particular case, image it on an iPhone camera, which is very, very good, turns out. I think that's, and then, yeah, as I say, one of the things that we really try to do in our lab is, it's very easy with technology to try to build something and then kind of end it. We really try to go that next step, which is to take it to the next level and commercialize things. This is one of my students, he happens to be here this week for the Cornell Venture Forum. One of the students is now has licensed this technology with a partner and is starting doing a startup around this. And so if anybody's interested in those kinds of things, that's something I could talk about maybe during coffee break here. So I'll end there. Like I say, I'm happy to answer any questions, but I can also chat up here for a few minutes. That's our website. If you really want to be part of an exclusive group, you should follow me on Twitter. Yeah, thank you very much.